Hello and welcome to the Citizen CPR Foundation's first virtual summit. I'm Vinay Nadkarni, past president and program chair.
Hi, everyone. I'm Paula Lank, chair of the Citizen CPR Foundation, and we welcome you to the summit.
Welcome, everyone. My name is Stu Berger, and I am the president of the Citizen CPR Foundation. We are so excited that you joined us for the summit. The Citizen CPR Foundation is transforming to a focused year-round initiative and actions groups that brings people together, a unique combination of partners and affiliates. We are all working very hard and together to achieve our shared mission to increase survival from sudden cardiac arrest, and also to focus on survivors and families of those who have lost loved ones to sudden cardiac arrest.
Well, Stu and Paula, we really have an exciting program planned for the next couple of days. We're going to dive right into the science. Bob Newmar is going to start out with talking about the perspective of ILCOR, followed by Raina Merchant talking about AHA, and then Dave Markenson, the American Red Cross perspective, and then closing it out with Tom Aufderheide, our past president, who's going to talk about the exciting new science that was presented at the Resuscitation Science Symposium.
Great. I also want to let everyone know that we have an incredible group of exhibitors. Take the time to click on the exhibitor tab and select the logo for the exhibitor that you want to start with and see what new things they have to offer. We also want to take a moment to give a shout out and a thank you to the American Red Cross and the American Heart Association for their support in helping to plan and develop programming for this summit. Now, let's get started with the summit.
Hey, good morning from Arizona. My name is Brandon Griffiths, and I am the owner and founder of Griffith Blue Heart, where we prepare, train, and equip law enforcement for cardiac emergencies. I am a police officer and an out-of-hospital cardiac arrest survivor. I've been asked to kind of briefly share my story with you today. I was 26 years old when I suffered my cardiac arrest. Being a cop, I wish I could tell you that I was in a foot pursuit or doing something cool, but like 4 out of 5 cases, I was at home. I was sitting with my wife reading a book. I set it down, said I was going to take the dog out, and I instantly collapsed into my bookshelf. My wife went to brace me, and I'm 6'4". She's about 5'3". I toppled right over her and put my head through the wall. I dropped dead right then and there. My wife sprang into action. She called 911, rolled me over, and immediately started doing CPR. She worked on me until a fellow first responder, a police officer, arrived and took over compressions. He did a phenomenal job. He worked on me until fire and EMS later arrived, and they were able to successfully resuscitate me. All in all, I was medically dead for about 16 minutes. I cannot tell you how grateful I am to have been given a second chance, and now I strive to earn each day that I'm given. Last year, I was honored to be one of the recipients of the Citizen CPR Foundation's 40 Under 40 Award. It has afforded me the opportunity to sit on their committee for the 40 Under 40 with incredible individuals with amazing backgrounds. One of our first initiatives was to do a PSA video educating the public on cardiac arrest to raise awareness. We wanted to feature actual out-of-hospital survivors under the age of 40 to highlight the fact that cardiac arrest can happen to anyone, anywhere, and at any time. We wanted this video to serve as a call to action, not only for people to learn CPR and how to use an AED, but to act without hesitation if and when that time comes. It coincided with the launch of World Restart a Heart Day back in October, but we actually have the video here today to present to you, which we will do right now.
When you hear cardiac arrest, what do you think of? This? Or this? Cardiac arrest is not a heart attack. It happens when a person's heart stops beating normally, causing them to collapse.
It happened to me.
It happened to me.
It happened to me.
It happened to me.
Doing nothing or waiting for the professionals to arrive increases the chance of death because the brain and heart are quickly dying. Don't wait. Act. The only effective treatment for cardiac arrest is CPR and the use of an AED.
We are alive today because my husband did not hesitate to act.
Hi, I'm Brittany, and I'm alive today because two strangers knew CPR.
All right, I hope you all enjoyed that video. We worked pretty hard on it. So I want to welcome you all to our plenary session, Putting Science into Action. Before I introduce our moderators, a reminder, on the right side of your screen, you're going to see a chat box. We encourage all of you to type any questions you may have to our speakers there, and they'll get back to you by the end of the session. It's my privilege to turn the session over to our moderators now, the first being Dr. Stu Berger. He is the Division Head and Pediatric Cardiology Co-Executive Director of the Heart Center at the Ann and Robert H. Lurie Children's Hospital of Chicago, and the Getz Professor of Pediatrics and Director of Northwestern University's Project Atom. Our other moderator is going to be Dr. Joe Rossano, the Chief of Cardiology and Executive Co-Director of the Cardiac Center at the Children's Hospital of Philadelphia.
Good morning again. Thank you, Brandon. Joe and I are truly honored to be part of this incredible experience where we bring together a group of people and organizations, as mentioned, that are integral to the science and implementation of new guidelines, and hence, of course, our ultimate goal of doing our very, very best collectively and together to save lives.
This is the common goal of every single one of us, no matter what organization or organizations we work with, to save lives. And although we do understand the science and we do implement changes to make things better, we absolutely do have a ways to go to move the needle a significant amount. Both bystander CPR rates and out-of-hospital cardiac arrest survival rates are far from optimal. And the organizations that are with us today are key in the education of providers, educators, as well as the lay public.
The title of our plenary, as you all know, Putting Science into Action, really does say it all. Each of the people and the organizations that we will hear from this morning, the American Heart Association, the American Red Cross, ILCOR, RES, which is the Resuscitation Science Symposium, are truly key members of this critical community. Having each organization speak on the very same podium, albeit a virtual podium, is incredibly meaningful and critically important. I wanted to let you know about the format of this 50-minute plenary session. We will have a 5 to 8 minute individual presentation by each of the 4 individuals representing the organizations mentioned. We'll have a 20 to 30 minute session with moderated, presented, pre-planned guided questions. And then we will have an open discussion and question period after that. Thank you all for being part of this exciting session, and thank you all for joining us for the virtual summit.
I'm honored to introduce our first speaker, Dr. Robert Newmar, the ILCOR co-chair and professor and chair of emergency medicine at the University of Michigan, to discuss the 2020 ILCOR co-star. Dr. Newmar.
Inviting me to participate in this very important conference. The title of my talk is ILCOR 2020 Consensus on Science with Treatment Recommendations. These are my disclosures. Relevant, I have equipment support for laboratory research from Physio-Control Stryker. And the learning objectives of my presentation are to understand the structure and function of ILCOR, gain some insight into the ILCOR evidence evaluation process, and highlight some important or controversial updates and changes in the 2020 ILCOR Consensus on Science and Treatment Recommendations. The International Liaison Committee on Resuscitation, or ILCOR, was founded in 1992. And really, the purpose of ILCOR is summarized by one of the founding fathers, Douglas Chamberlain, who stated that someone's likelihood, or how someone is treated for cardiac arrest and their likelihood of survival, should not depend on where in the world it occurs. And at that time, there was very different and dispersed guidance on how to perform cardiac arrest resuscitation. And the wisdom of the founding fathers of ILCOR really thought it would be valuable to bring together the world's experts to review the available science and create a consensus for treatment recommendations that member councils could use to develop their local guidelines. And this figure shows you the member councils of ILCOR. We have the Heart and Stroke Foundation of Canada, the American Heart Association, the Inter-American Heart Foundation, European Resuscitation Council of Southern Africa, Resuscitation Council of Asia, and ILCOR, which is the Australia-New Zealand Resuscitation Council. And really illustrates that ILCOR has been able to bring together the world's experts in resuscitation science to provide the best and most insightful evaluation of the research and provide treatment recommendations. The vision of ILCOR is to save more lives globally through resuscitation, and its primary function is the evidence evaluation process that does generate consensus on science and treatment recommendations that are used by resuscitation member councils, such as the American Heart Association, to create their, and Red Cross to create their treatment guidelines. So ILCOR is made up of 6 task forces focused on specific areas of resuscitation: adult life support, basic life support, education, implementation, and teams, which focuses on coordinating both education and the system of care, first aid, pediatric life support, and neonatal life support. These task forces during the evidence evaluation process are supported by expert systematic reviewers who have expertise in literature searches and assessment of scientific literature, or on a larger scale, knowledge synthesis units for very complex questions that span multiple patient populations. And this entire process is coordinated by a science advisory committee that has significant expertise in evidence evaluation and guideline development. The process can be summarized by this figure. So anytime there's a question about resuscitation, diagnosis, or treatment, a PICOS question is generated, which the PICO stands for Population, Intervention, Comparator, and Outcome, and ST stands for the setting and the time frame. And these are structured questions that drive literature searches to answer specific questions. For example, in a population of in and out of hospital cardiac arrest, does epinephrine compared to no treatment improve survival and neurologic outcome? After the PICOS questions are generated, then a structured, extensive, comprehensive literature search is performed. And then the expert systematic reviewers, knowledge synthesis units, and task force members evaluate that literature using standardized grade methodology, which is an international standard for evidence evaluation, and then come up with what we call consensus on science with treatment recommendations, which is a summary of what the science tells us, and then treatment recommendations that are then available for member councils to develop guidelines. And this is just another cartoon summarizing that process where ILCOR, just to clarify that ILCOR does not generate treatment guidelines or course materials, but just provides the treatment recommendations that member councils use to create their guidelines and course materials. So most recently in 2020, this is just an example of how this work gets published. So we typically publish the work in both circulation and resuscitation. This is just a screenshot of the executive summary of the 2020 CoStar, which then is published simultaneously. American Heart Association publishes their update on guidelines for cardiopulmonary resuscitation and emergency cardiovascular care. So what's new for 2020? So I decided to just pull out a few highlights from adult basic life support, advanced life support, and pediatric life support, just to highlight either areas where we think it's important there for emphasis, or there's new or modified guidelines. So in terms of adult basic life support, the main focus really is to reduce the time to treatment for patients with cardiac arrest. So involving both recognition, early recognition, and early intervention. One new recommendation is that we recommend that lone bystanders with a mobile phone should dial EMS, activate the speaker or hands-on free option of the mobile phone, and immediately begin CPR with dispatcher assistance if required. And I know this sounds intuitive, but it never was a specific recommendation since we've evolved into the cell phone era. And again, the focus of this really is to minimize the time to intervention. So both activating the EMS system and then simultaneously starting CPR when you're a lone provider, when you have a mobile phone available, is something that we envision will be able to reduce time to both EMS activation and initiation of chest compressions. A second recommendation is somewhat of a modification or update of the importance of 911 dispatchers in the care of patients with out-of-hospital cardiac arrest. We recommend that dispatch centers implement a standardized approach to immediately determine if patient is in cardiac arrest at the time of an emergency call. And this is driven by the science that demonstrates significant delays in the recognition of cardiac arrest, even when the cardiac arrest is being monitored by a dispatcher. And we know that time to chest compressions is a significant impact on patient outcomes. And then we also reiterate our recommendation that dispatchers provide chest compression only CPR instruction for all patients, adult patients. And then the third recommendation that is new for ILCOR is related to Narcan in suspected opioid overdose. In the previous iterations of the ILCOR co-stars, we did not make a recommendation about Narcan, and our updated recommendation is that we suggest CPR be initiated without delay in unconscious person not breathing normally, and that naloxone be used by lay rescuers in suspected opioid-related respiratory or circulatory arrest. And although this is not based on any new randomized clinical trials or robust scientific research, we felt that it's important to add this to the therapy in the consideration, especially in areas where the opioid epidemic is significant. So for advanced life support, there's a number of important controversies. One is the emergence of double sequential defibrillation, where two defibrillators are applied, one with standard pad application and one with anterior-posterior pad application. And this has emerged in a number of case studies that have shown a potential benefit. There's one pilot study that has been performed that suggests there could be potential benefit, but there's a larger randomized clinical trial pending. But based on the available evidence, ILCOR suggests against the routine use of double sequential defibrillation strategy in comparison to standard defibrillation from cardiac arrest with a shockable rhythm. And one of the reasons is that the evidence of the pilot study suggests it may be the vector change rather than the rapid sequential defibrillation that impacts the benefit, and more science is needed to develop the optimal therapeutic approach. Second, some retrospective analysis of prospective clinical trials looking at whether IV or IVO drug delivery is better, suggested, at least in one of those retrospective studies, that IO access might be inferior to IV access in drug delivery in adult patients. So we have basically previously stated that they could be used equivalently, but the new updated statement suggests IV access first as compared to IO access in the first attempt for drug administration during cardiac arrest. And then finally, for ALS, there's an emerging popularity and use of a bedside point of care ultrasound for both assessment and prognostication during CPR. However, the review of the evidence does suggest that use of lack of cardiac activity, for example, in prognosticating futility in CPR is not a reliable strategy to prognosticate futility. So this we suggest against the use of ultrasound for that purpose. Pediatric life support, the reiteration that bystanders should provide ventilation for infants and children younger than 18 years was thought to be important to emphasize, especially in the light of the COVID pandemic. There was a review of a number of retrospective studies looking at time to initial dose of epinephrine and resulted in a suggestion that an initial dose of epinephrine in pediatric patients with non-shockable rhythms should be administered as early as possible. And then in light of this Society for Critical Care Medicine update on sepsis treatment in infants and children, there was an updated recommendations from the Pediatric Life Support regarding sepsis, specifically regarding initial fluid boluses in children with septic shock. Finally, ILCOR did make some recommendations in response to the COVID pandemic, which has a significant impact on both patient outcomes and provider risk of infection, both in the lay providers and for the EMS providers. And just to quickly reiterate those, that we continue to suggest chest compressions and there's evidence to suggest that chest compressions and cardiopulmonary resuscitation could generate aerosols during CPR. There's limited evidence here, but it is something that needs to be considered in decisions to treat. However, given the risk benefit of initiating CPR in patients, we still continue to suggest that during the current COVID pandemic that lay rescuers consider chest compressions and public access defibrillation as a good practice statement. We also suggest that during the COVID pandemic, lay rescues who are willing and trained to do so consider providing rescue breaths for infants and children in addition to chest compressions. We suggest that all healthcare providers should use PPE appropriate for aerosol generating procedures during resuscitation, and that in the case of initial defibrillation of someone before donning PPE, we suggest it may be reasonable for healthcare providers to consider defibrillation before donning PPE for aerosol generating procedures in situations where the provider assesses the benefit may outweigh the risk. And with that, I will finish my talk and be available for questions at the end of the session. Thank you.
Thank you so much, Dr. Neumar, for that wonderful information. It's an honor for me to introduce our next speaker, Dr. Raina Merchant. Dr. Merchant is the American Heart Association ECC Chair. She is an Associate Professor of Emergency Medicine at the University of Pennsylvania, and also has joint appointments in the Department of Anesthesia Critical Care and in the Department of Medicine. Dr. Merchant will discuss the science and controversies behind the 2020 AHA guidelines, and Dr. Merchant will do this by video. So here we go.
So welcome, and I am so excited to be here with you today virtually. My name is Dr. Raina Merchant, and I'm an emergency medicine physician at the University of Pennsylvania, and I am the chair of the American Heart Association Emergency Cardiovascular Care Committee. I'm going to be chatting with you very briefly about putting science into action and the science behind the 2020 guidelines. This is my disclosure information, and I don't have any disclosures regarding this presentation. Today, I'm going to talk about the current climate of resuscitation science, provide an overview of the guidelines process, and review highlights from the 2020 guidelines. I'm going to start with what I've put on the slide in bold. Resuscitation science is more critical now than ever. We are meeting in the context of the confluence of two events which are unprecedented in history and have never occurred in this context before. The first is the COVID-19 pandemic, which has affected individuals globally and at the magnitude of millions. We're all aware of the significant impact that it has had on public health in every facet, as well as on the social and economic fabric of our society. And at the same time as COVID-19 has been occurring, we are also at this moment of a national reckoning and awareness around racism in the aftermaths of the deaths of George Floyd, Breonna Taylor, and numerous others that have really refocused the conversation and attention towards addressing and thinking more clearly about racism and its impact on public health. As I wrote these slides on December 2nd, the numbers will have changed by the time that you're hearing this. At this moment, there are more than 64 million cases of individuals who have or have had COVID-19, with almost 1.49 million deaths. And in the United States, there have been more than 13.9 million individuals affected and more than 250,000 deaths. I want to reference this piece by the respected scholar and emergency medicine physician, Sarah Perman, who wrote a piece on my mind about overcoming fears to save lives. It is because of this pandemic that there is an incredible threat to bystander CPR in both the out-of-hospital and in-hospital setting. And really thinking about how this pandemic has affected resuscitation is critically important. And as I mentioned, at the same time, there's a national reckoning and focus on disparities in care and in outcomes, which we've already seen in relationship to COVID-19, but also there's data that's emerging about how this is impacting patients who are having cardiac arrest. This is a paper in JAMA Cardiology, which looks at the characteristics of those with cardiac arrest and resuscitations that have happened during the novel coronavirus. And there are other reports that have come out of the CARES database, as well as get with the guidelines, that are really focused on how is this pandemic and these issues of equity and disparities really impacting the practice of resuscitation. So I come back to my initial slide. Resuscitation science is more critical now than ever. We have to know the data. It's imperative that we all respond, react, resuscitate everything we've got in order to save lives. And so that's in that context, I'm going to give you an overview of the 2020 guidelines. Now the guidelines, of course, the process of working on the guidelines started well before the pandemic and well before this national reckoning around racism. And yet what's in these guidelines is so important for how we think about the practice of resuscitation now and in the future. I'll talk about the process first. We've heard a bit already from Dr. Newmar about ILCOR and its critical role across its member councils in helping to develop these guidelines. And ILCOR works very closely in partnership with the American Heart Association in conducting systematic reviews, scoping reviews, and evidence updates that help to bring together the most up-to-date science about resuscitation. Each guideline is associated with a strength of recommendation, that's the class, and a level of evidence, which gets at the quality of the recommendation. I'm going to go through the different ways in which the guidelines are distributed across adult, pediatric, neonatal, education, and systems of care. And I'm really just going to give you the highlights, just the things kind of, if you only know a couple things out of the document, what are the things that stand out? In the adult guidelines, there's a renewed focus or continued focus on high performance CPR. On early defibrillation and the administration of epinephrine is also highlighted in the guidelines. There's also a new focus in the chain of survival in the addition of post-cardiac arrest care. And I encourage you to look closely at the guidelines because it talks about therapeutic hypothermia and a whole other suite of processes and approaches which are being used to really optimize care for patients after they've survived their cardiac arrest. This is the only slide that I'm going to show that has the algorithm, but all the algorithms have been updated in 2020, and they're easy for you to be able to use to look at either before an event or in the midst of an event that allows you to really quickly go through the steps of what's needed for responding. There's also a focus on cardiac arrest and pregnancy, and this is also new in the guidelines. It really focuses on the importance of a whole maternal cardiac arrest care team in providing care for the mother and the neonate. Considering the public health emergency that we are facing related to the opioid crisis, there's also a focus on opioid use disorder and cardiac arrest, and the importance of activating EMS, high quality CPR, and for those in respiratory arrest, considering naloxone or the use of naloxone. The pediatric guidelines also focus on the importance of high quality CPR. There's a theme here. High quality CPR is really important. And a change that I want to draw your attention to is the focus on the respiratory rate of 20 to 30 times per minute for both infants and children that are receiving CPR with an advanced airway in place or receiving rescue breathing and have a pulse. Early epinephrine is important, and considering a cuffed endotracheal tube as it can decrease the need for cuff changes later on, for endotracheal tube changes later on. The pediatric section also focuses on post-resuscitation care. In terms of the neonate, there's a lot of focus on the care and the management of the umbilical cord, skin to skin immediately after the baby is delivered, and different forms of access in terms of umbilical venous catheterization, and that an IO can be used as an alternative. There's a lot of information in the education system. The way that we provide and give people information about the guidelines is constantly evolving. And the current 2020 guidelines really review booster training, different intervals of training being received, the use of devices, and a real focus on practice and mastery. And the way in which we deliver these tools is also changing. There's a focus on high fidelity mannequins, using games to make training more engaging, in situ training, and really focusing on holistically on the entire team in terms of teamwork and leadership. Systems of care has a broad range of information around debriefing, registries, important focus on the entire community, telecommunication CPR by EMS, and then also there's a section on drones and their potential role in helping to bring defibrillators and enhance just-in-time training. I want to conclude by encouraging you to go to eccguidelines.heart.org to get more information. This was just a brief overview, but I hope that this will inspire you and that we are at just an incredibly unique time in history where resuscitation science is critically important. Thank you so much.
Great. Thank you, Dr. Merchant. That was a wonderful talk. It's now my privilege to introduce Dr. David Markenson. Dr. Markenson is a pediatric emergency medicine and critical care physician and is the Chief Medical Officer of the American Red Cross. He will discuss the science currently being applied to the 2020 focus updates by the American Red Cross. Dr. Markenson.
Thank you so much, and it's my privilege to be here. Hopefully in the next few minutes, I will be able to give you a high-level presentation on science and controversies behind the 2020 American Red Cross focus updates and guidelines. It is my privilege and honor to be here. I would like to thank the organizing committee for inviting me. I also really am honored to be part of this panel with my colleagues from ILCOR, my colleagues from the American Heart, and from the resuscitation science aspect of resuscitation science. The learning objective obviously is to provide the information from these updates. In terms of disclosures, the only disclosure I have is I have moved from a volunteer to the full-time Chief Medical Officer with the American Red Cross. And as many of you know, the Red Cross does cover resuscitation science, but there is so much more and it sort of intertwines. The work we do in resuscitation and life-saving spreads out across our other work, and our other work informs the work we do in resuscitation, whether it's from our disaster relief, our biomed and blood services, the work in the international community. And it's always fun to look back a little bit on the historical context. The American Red Cross has been delivering resuscitation training and science going back to almost linked to the foundation of the Red Cross movement. For those who don't know, the Red Cross movement was really started by the need to provide emergency care at the battlefield. That helped start the Red Cross movement and also the Red Cross within the US. And it was always response to the needs of the community, whether the needs of factory workers and the lack of safety, training of nurses and civil defense. But the nice thing about this is it gives a broad foundation for the science that's informed by what the questions are the communities we serve need. And this comes from international organizations like where we run hospitals in Japan, to workplace, to hospitals. And so it's really that full breadth and depth of all of resuscitation that is key for us to cover in these scientific updates. And like I said, we have that nice closed loop. We look at the science from the questions from the broad audiences we serve, whether they're in hospital, pre-hospital, international, and then after the course is delivered, we get the feedback of how did the science hold up and where else do we need to look going forward. So again, key aspects of it is all of our programs are grounded in our scientific update. But a key aspect is as we look at resuscitation across all etiologies and all environments of resuscitation science, our focus updates and guidelines don't only look at cardiac etiologies and cardiac resuscitation, but the full spectrum. Obviously, this has to be overseen by a group, and this is overseen by the American Red Cross Scientific Advisory Council. But as you've already heard from a prior presenter, really one of the best collaborations developed what's known for resuscitation cardiac science, cardiac etiology, cardiac resuscitation is ILCOR. And we are proud to partner and participate in those task forces and to really look upon ILCOR for those great systematic reviews in cardiac resuscitation and care. We also have our partnership through the IFRC, International Federation of Red Cross, the member organization of all the Red Cross societies nationwide and internationally, who do science systematic reviews we look at. But then again, we look to other partners here within the US who do their own systematic reviews and really help set the national standards for science across different aspects of resuscitation. Examples of those: Surviving Sepsis and the College of Critical Care Medicine, College of Emergency Physicians, American Academy of Pediatrics, ACOG. And when you're hearing about the real need to address the pregnant female, there is something called OBLS, which is a consortium of experts who are the leading thought thinkers and science reviewers in obstetric care, and we look to them. So just to highlight on a few of those aspects, the Red Cross Scientific Advisory Council, which provides the oversight of all these programs and the scientific review, is really a group of 60 national and international experts in the various fields related to resuscitation, first aid science, drowning process resuscitation, nursing education, aquatics. We're divided into 5 groups based on our areas of expertise: resuscitation, first aid, education, preparedness, disaster health, and aquatics. And what does this group do? It either evaluates systematic reviews or, more importantly, creates new systematic reviews to give evidence guidelines on what people who look for our training and guidance need. In addition to the scientific reviews, this council also provides answers to very specific questions, reviews all programs, and serves as our liaison to other evidence review processes. As I said, we're a member of the International Federation of Red Cross. That group puts out guidelines every 5 years that are international and relate to the work of 190 societies. Like ILCOR, they really coalesce international science that each country can include. What's unique about this document is it's broad in that it looks at conflict zones, disasters, and not only cardiac, but wide spectrum. And I know I have a few minutes because this is really a high-level overview, but I wanted to give you the why behind the guidelines. And the guidelines that were published by the American Red Cross in 2020 include the full spectrum of impact that our programs had: first aid, BLS, ALS, pediatrics, neonatal, education, aquatics, and disaster health. And while we don't have enough time, and I have presentations later in this meeting to go into depth, and so do my colleagues, I wanted to give you a highlight of a couple things from each of these. Within first aid, the key aspect is it's hemorrhage, hemorrhage, hemorrhage. And unfortunately, due to a lot of world events, we've learned a lot more about hemorrhage control and how early, and really the emphasis here is on early and looking at unique aspects like pediatric tourniquet, as well as different compression techniques. Again, opioid crisis, but also some common problems we see are syncope and environment, and looking at the science are there things we can do early to prevent those from getting worse? BLS, the American Red Cross programs have always highlighted ventilation in children and infants, and the new guidelines continue to do that. But we also have unique recognition that the drowning process resuscitation is special and requires unique intervention. We also go over things like foreign body airway. Under ALS, highlights about COVID-19, again, with our partnership with the OBLS program, significant depth, breadth, and guidance on OB care, sepsis care, and really, we're now moving only from resuscitation, but the full spectrum, not just the immediate resuscitation, but how do we improve outcome with post-resuscitation care? In PALS, as you've seen through our BLS courses, we've always emphasized that kids are different and require different ventilation strategies. That continues in these guidelines. We also have looked at ways to reduce fatigue and give better compressions, and things like the 2 thumbs that was once believed to be for professional 2 rescuers, we've now shown is great for single rescuers and can really improve outcome. And again, this is just really high level. The resources that are out there for you are our focused update and guidelines, highlights, and the full science document, which was published in November of this year, and also the modification for delivery and educational programs. And so with that, I'd like to thank you all. I really appreciate being with this esteemed panel, and I'll turn it over to my colleagues for their presentation.
Dr. Markenson, thank you very, very much for that update. And I know we will hear more from you later. Our final speaker in this session is Dr. Tom Aufderheide. Dr. Aufderheide is the RES co-chair. He is the director of the Resuscitation Research Center at the Medical College of Wisconsin and is a professor of emergency medicine also at the Medical College of Wisconsin. Dr. Aufderheide, it is a pleasure to introduce you.
Thank you very much, Stu. It's an absolute pleasure to be here today. I'm going to be talking about science-driven and evidence-based new understanding of the process of death based on 3 important studies that were published this year. Learning objectives are shown here, and presenter disclosure information is on this slide. Note that I will be talking about unlabeled and unapproved uses of ECMO-facilitated resuscitation in 2 studies in which I played an integral role. So death is not an event. It is a process. And a process can be successfully interrupted and reversed. So how long is the process of death? Well, most medical professionals and the public believe that death is inevitable after 3 to 4 minutes without oxygen. So what is the scientific origin of this belief? And is it true today? So I'm going to review 3 scientific studies published this year that provide strong evidence to the contrary. So our belief in this 3 to 4 minute rule really comes from 2 studies 80 and 60 years ago. This first study was from 1940, in which investigators interrupted the blood flow to 12 cats' brain and demonstrated permanent pathologic lesions when the circulation was interrupted for 3 minutes and 10 seconds. The second study is from 60 years ago from Johns Hopkins that looked at 132 human cardiac arrests that occurred in the operating room. At that time, the only form of resuscitation was open chest CPR, and they found that almost all patients died unless resuscitation occurred within 4 minutes from resuscitation. And these 2 studies, 60 and 80 years ago, still dictate our beliefs today. Until this year. So this year, this study, Restoration of Brain Circulation and Cellular Functions Hours Post-Mortem, was published. Basic science colleagues had developed a new perfusate, a liquid that could be perfused in organs to keep them preserved and keep them alive. They decided to test their new invention, their new fluid, on the most sensitive organ possible, and that was the brain. They discovered that pig slaughterhouses slaughtered pigs by decapitation, and that they threw away the heads as discarded material. So they went to a slaughterhouse and asked if they could take a few of these pig heads back to their laboratory, and were granted permission to do so. They were going to be thrown away anyway, and reperfuse these brains in a pulsatile way. Through their basic science processes, they demonstrated first that vascular function was restored and maintained, the arteries dilated and constricted back again normally, cell death stopped, the nerves and synapses were restored with electrochemical function. That is, they conducted electrical impulses. Other cells in the brain were preserved, including glial cells. Inflammatory function was restored. And in fact, the entire global cerebral metabolism was restored and maintained. They importantly pointed out that global EEG activity consistent with consciousness did not occur during the time frame of the study, and therefore they indicated that they had no reason to believe that these animals suffered with this experiment. They concluded that global cerebral metabolism can be restored multiple hours after death, and the minimum time that the investigators used in this study was 4 hours post-mortem. 2 other studies provide scientific evidence that the process of death is a lot longer than any of us had believed. This is the ARREST trial, in which I was a senior author and played an integral role. This study was the first prospective randomized study of ECMO-facilitated resuscitation versus standard of care in patients with out-of-hospital refractory ventricular fibrillation. And patients were randomized on hospital arrival to receive standard ACLS treatment versus ECMO-facilitated resuscitation. These patients received an average of 1 hour of CPR, and many of them received over 1 hour of CPR. ECMO-facilitated resuscitation survival was 43% versus standard treatment survival, which was 6.7%. The cumulative survival difference between these two groups was very significant, with a p-value of 0.0001. Functionally favorable survival is shown in this slide. The one patient with standard treatment died 2 months post-discharge. All ECMO-facilitated patients had functionally favorable survival at 6 months. A second study delivering ECMO-facilitated resuscitation to the entire metropolitan area of Minneapolis and St. Paul was also published. The administrative infrastructure, the geographic locations covered, as well as the process by which ECMO-facilitated resuscitation was delivered to the entire community are reviewed in this paper. It reviewed 58 consecutive patients. These patients also received about an hour of CPR, a little less than the randomized trial. And functionally favorable survival was similar, if not close to equal, with 43% functionally favorable survival at hospital discharge and 3 months. Reviewing ECMO-facilitated resuscitation, shown in the blue bars, you can see that we've now demonstrated that functionally favorable survival occurs routinely past 1.5 hours, and that time limit has not yet, the limit of that time has not been determined yet. So what have we learned? We've learned that the process of death is much longer than generally recognized, and that the resilience of the brain to recover from ischemic insult is much greater than we have thought in the past. This evidence extends the new window of opportunity for new and more effective resuscitation interventions. There's a critical need to develop effective neuroprotective strategies. And moving forward, we need to recalibrate the public and especially healthcare beliefs and opinions about our new understanding of the longer process of death and incorporate that into our collective practice. Well, what do we do now? Well, come back to earth and understand that all aspects of good resuscitation practice apply now more than ever. We need to strengthen the chain of survival throughout our communities, promote CPR and AED education and training, strive to achieve the shortest times possible to return to spontaneous circulation, and provide consistent, high-quality delivery of the new CPR guidelines. Thank you.
Thank you, Dr. Aufderheide. Unfortunately, maybe for good reasons, we probably will not have time for our Q&A as we're running out of time. So we encourage all of the attendees to reach out to the speakers directly or to the organizations for questions. And I do believe there will be other opportunities over the next couple of days. We would like to thank everybody for attending the session. And thanks to our speakers for giving some wonderfully provocative talks, sharing information, and really setting the tone for the rest of this virtual session. We also want to encourage everybody to please stop by the exhibitors during the break, not only for the next 10 minutes, but through both days. All the people in the exhibits have spent time preparing relevant information for us. Defib will be demoing during this break, and we're very thankful to all of the exhibitors for being here. So once again, thank you all very much. This is the beginning of a very exciting 2 days, and we look forward to the rest of the sessions. See you all very soon, and we will reconvene at 11 a.m. Central, which is 10 minutes from now. Thank you all very, very much.